My strange journey. A little bit about my strange journey today, sure. But it's a pleasure meeting you.
Good to have you.
Thank you.
Good morning. Welcome to the ETSU Department of Psychiatry Grand Rounds. Today we welcome Dr. M. Anthony Graham, who is an associate clinical professor here at the ETSU Quillen College of Medicine in the Department of Psychiatry. He's currently a psychiatrist at the Mount Rogers Community Services Board. Dr. Graham completed his undergraduate training at the University of Virginia's College at Wise, completing a Bachelor of Arts in Chemistry and Biology. He attended Medical College of Virginia in Richmond, completed his internship at Orlando Regional Medical Center, University of Florida Affiliated Hospital in Orlando, and his residency at Johns Hopkins Hospital Department of Psychiatry in Baltimore. He is board certified in psychiatry and neurology, and today he's going to be discussing telepsychiatry. It should also be noted that Dr. Graham was actually the first National Chief of Telepsychiatry at the VA and has a lot of experience working in rural settings, providing psychiatric care to those who would not otherwise be able to access it. So welcome. Thank you.
Good morning. Can you all hear me okay? Yes? Okay. Good. I tend to wander a little bit. My name's Tony Graham. And I was here, I guess, a couple of years ago, presenting on this topic of telemedicine and telepsychiatry, and so were kind enough to invite me back to maybe update a little bit in terms of a field that's rapidly changing and also has had a lot of impact in a lot of different areas in psychiatry and mental health. Anybody know where this is located? If you do, you get an extra gold star. Does anybody see the advanced technology in this picture? No, you don't. This is Hungry Mother State Park. I live in Marion, Virginia, which is in Smith County, up the road about an hour and 45 minutes drive as you're going up from here towards Roanoke or Virginia Tech or any of those places that people zoom by. One of the places you'll zoom by is Marion, Virginia. And this is Hungry Mother State Park. And the technology, I forgot the technology. My friend who's a bank manager in Marion, he got himself a toy a couple weeks ago, a drone. And these are drone photographs of him self-controlling his drone as it's flying over Hungry Mother State Park. So technology has a way of inserting itself into our lives in a lot of different ways, and that's part of what I'm going to talk with you about today. My disclosure, I don't get anything from anybody, any place that's relevant in terms of this particular topic. Telepsychiatry. Today I'm going to talk a little bit about the definitions, a little bit about the historical context of telepsychiatry, and I hope to share with you some of my own journey and how I got involved in the area of video conferencing and telepsychiatry in the first place, and some of the clinical applications, more recent applications in different areas, some examples of projects and activities that I think are of interest, and maybe a little discussion about where do we go from here? Where does this type of technology take us in the coming years? How many people in here have done interactive video conferencing to see patients? 1, 2, 3, 4, 5. Okay. I've been doing presentations about telemedicine for over 20 years now. And when I first began to ask that question, there were none. How many people in here have a Facebook account? Okay. That's a lot higher percentage than even 2 years ago when I asked that question, when it was mostly the students who raised their hand yes, and all the faculty pretty much no. How many have a LinkedIn account? All of these are, of course, examples of technology inserting itself into our lives and into our professional practice. And today, I'm going to limit this talk to really talking about video conferencing in the care of psychiatric patients and in mental health settings. I'm not going to talk today about all of the other associated issues like social media, online, e-therapy, all of these various things, which are certainly interesting topics, but I'd have to be here until next Tuesday to touch on all of these areas. No, I'm going to talk about video conferencing in particular. Let me tell you a little bit about my own journey in this. After I got out of residency at Johns Hopkins in 1986, I was sent by the National Health Service Corps, because I had a scholarship obligation, to what was then the old state hospital, Southwestern State Hospital in Marion, Virginia, that at that time was about 720 beds, and I was one of 2 psychiatrists at that facility. It was an old state hospital with lots of difficulties, and it served that and still continues to serve, that southwestern Virginia collection of communities from Roanoke all the way south to Bristol and all the way west to Wise County and the Kentucky border. All of the region and counties are served by the state hospital in Marion, Virginia, that's been there since 1887. It was the 3rd state hospital in Virginia. Over the course of years, they rebuilt the state hospital. I was privileged enough to become medical director there and had been working on this issue of how do you get psychiatrists to come to Hayside, Virginia? Well, the short answer is you can't. We were working regionally on recruitment incentives, paybacks, geographic differentials in pay, but essentially a lot of the care was being provided. We would send state hospital psychiatrists, or myself would circuit ride to community mental health clinics in different areas to provide limited amounts of services. Then in 1994, there was a project that I'm going to tell you more about in just a few minutes that we set up through a demonstration grant from the Office of Rural Health Policy. We set up one of the first telepsychiatry linkages in the United States, the Appal Link project, or the Southwestern Virginia Telepsychiatry project, that went online in 1994 and began seeing patients. And again, I'm going to talk a little bit more in detail about that. The area of telemedicine, this slide, some of you may have seen this ad. It was from a magazine that was by a visionary German author, Hans Gernsback. And you can see the little boy, he's saying ah into a device, and you see the doctor there on the screen and some data that's being transmitted there on the sheet of paper and is being seen by telemedicine. Now, the interesting thing about this, of course, is the date, which is 1924, well before even the first television communications were identified. So there's something about this idea that goes back quite a ways in terms of receiving healthcare services using communication technologies. was sort of the godfather of telepsychiatry, Dr. Cecil Whitson. In the late 50s, he was a psychiatrist in Omaha, in Nebraska, at the Nebraska Psychiatric Institute. And he had the idea that if he could set up a television linkage to the Nebraska State Hospital, that he could and did psychiatric consultations, group therapies, notes, education. He did it for 6 years there in the late 1950s using a closed-circuit television linkage. In the 1960s and 70s, there were a handful of other similar projects scattered across the United States. There was one in Boston at Mass General that connected Mass General with Logan Air Station and provided closed-circuit television psychiatry consultations, again, using a similar technology. And as you might think, doing it that way was very expensive. Creating an individual closed-circuit television linkage was not going to be sustainable. And all of these projects basically, and of course there were no personal computers, information technology was not available to support those kinds of projects at that time, and they all basically died out by the mid-1970s. In the 1990s, there was another wave of projects, and that was one of the projects when I first started to get involved in this area, because of advances in compressed video conferencing technology and the beginning availability of bandwidth to provide those services. And there were funding for a number of telemedicine projects in the United States by different federal agencies and some state agencies. And these are just some of them that were doing a lot of telepsychiatry activity in the 1990s. Some were academic centers, some were rural state authorities, and there were a number of different projects that were using video conferencing to provide psychiatry services in different parts of the United States. As I mentioned, I'm going to tell you a little bit about the project that I was first involved with, Appal Link in southwestern Virginia. The hospital there, I mean, East Tennessee and Eastern Kentucky and Western North Carolina and southwestern Virginia and southern West Virginia all share this region of Appalachia. And so a lot of these issues, we see the same people. The sort of boundaries and state approaches to care are very different. You step across the line in North Carolina, you're going to be in a very different mental health environment. You step across the line into Tennessee or Virginia or Kentucky or West Virginia, very different systems, delivery of care, access to care. However, a lot of the same types of problems that our patients struggle with are very similar, and a lot of this will be very familiar to you as well. This is mental health shortage area. This is 2002. Virtually, the number of psychiatrists in southwestern Virginia or rural areas along the borders of North Carolina. And the area that, there's a pointer here, I believe. This sort of area that just goes and goes west. If you've never driven all the way to the tip of Virginia, you can't believe that it actually goes. And when you get out to Lee County and Jonesville, you'll think you're driving to Nebraska. I mean, because it's quite a distance geographically across this region that the state hospital in Marion serves as the inpatient public psychiatry facility. And of course, all of these issues, lack of resources, distance, geography, poverty, coordination of care, lack of private resources, all of these have been chronic problems. They've been problems for many decades in terms of how do you provide good access to mental health services in areas of the country that are rural, isolated, and have very few psychiatric resources. So in 1995, a bunch of us got together in this regional community services boards. In Virginia, they're called community services boards. I don't know why. Every other state calls them community mental health centers, but Virginia, they're called community services boards. And the state hospital, we wrote a grant to see if the feasibility of providing services using video conferencing. And for those of you who've written grants, or it's sort of furious activity, you write this grant, you send it in, and you think, well, that's never going to get funded. And then all of a sudden, it got funded. And the next thing you know, I'm trying to figure out how do I talk with Sprint and AT&T about ISDN bandwidth, and they're looking at me like they have no idea what I'm talking about. There had never been any broad bandwidth ISDN lines anywhere in Southwest Virginia in 1994, commercial or otherwise. This service was not available. So the Wi-Fi and clicking on bandwidth and bandwidth, there was no bandwidth. In fact, we created the first ISDN network in Southwestern Virginia through this project in 1995. And, you know, at that time, you can see this is the punch board, which allowed the psychiatrists to control the cameras, the video conferencing. And for the purposes of the project, we had dedicated T1 lines because we didn't know what kind of bandwidth we would need, and we would use different bandwidths to see what kind of quality, what kind of image difficulties you would have. But at a dedicated T1 speed, I mean, it was like you see with the morning news guy talking on the TV to the distant remote. There was no lapse. The quality was very good, and as you go down in bandwidth, of course, you would run into all those difficulties. But back then, we had the luxury of using a high bandwidth connection. And there's one of our psychiatrists providing services. And for the 6 years that the project, we saw a number of patients. We provided almost 3,000 different psychiatric sessions. And we did a number of ratings that would describe clinical outcomes, satisfaction studies, both patients as well as providers. And it also improved the collaborative relationship between the state hospital and the community services boards. And the way this project was designed, and this is something I'm going to talk about in a little bit more detail, is that this technology, the important part of a project design is how you insert this technology into the system of care delivery. And so you have to know what it is that what currently exists and what you're seeking to accomplish by inserting this type of technology into an existing process of care, into an existing system. And projects that have done well have thought about that process, and projects that haven't done well have basically tried to graft this into areas on its own or freestanding, and it makes a lot more difficult in terms of designing things. In our project, I mean, the idea that I had back then is that if you could safely see patients using this video conferencing technology, perhaps it would enable me and other inpatient psychiatrists to see patients after they left the state hospital and went back to the community services boards for aftercare, follow-up, medication management, Now, previously, that was a discontinuous relationship. You would have an inpatient psychiatrist at the state hospital. I may have seen this patient 15 times over the course of 5 or 6 years, but I never once was able to see that person after they were discharged. A different psychiatrist, or sometimes a non-psychiatrist, or rotations of that, would pick up on the care of those individuals. So the insertion of this technology for this purpose enabled a relationship to continue that otherwise would come to an end. And a lot of patients, as well as the system, found that that component of it was valuable in terms of continuity, in terms of planning, and in terms of looking at symptoms as it related to functioning in the community and being readmitted in the future, perhaps to the state hospital. And so patients, of course, after informed consent and being introduced to the technology while they were inpatients, they would then be discharged and would be seen along with a nurse or a case manager at the distant mental health center by the inpatient psychiatrist who had cared for them on the psychiatric unit at the state hospital. And so the aftercare medication clinics was one activity. There were also other kinds of activities, joint treatment planning, family visits between distant, remote family who couldn't travel all the way to Marion. There'd be family visitations through the network. Commitment hearings were conducted using video conferencing. Forensic evaluations were performed. There were multi-point family support groups. The community mental health centers, or NAMI chapters in little rural communities, might have very small group, but this sort of enabled a multi-point video conference to provide a support group that was a regional process. And so there were a number of different activities in that particular project. Now, in 1997, I was asked by the then Undersecretary of Health, Dr. Ken Kaiser with the VA, was interested in setting up a national program office for telemedicine. And somehow he asked me to come to Washington. And so in 1997, I went to the VA central office in Washington and set up the first VA national office of telemedicine. And I'm going to talk a little bit about the explosion in telemedicine. And the VA has been a leader in telemedicine and telepsychiatry in particular, telemedicine in general, and telepsychiatry in particular over the last 20 some years. And to also talk about the explosion in usage in other areas across the country. Reasons for that, obviously, are there are many more technologies available now than 20 years ago. The technology that we introduced to do this in 1995, each unit cost $50,000. You can do the same technology now for $2,000 or $3,000. The same type of compression, the same type of quality, and of course the costs of bandwidth were extraordinarily high back then, and the decline in cost of available bandwidth, driven by commercial and entertainment and all kinds of non-health related reasons. But both of those factors have facilitated the growth and delivery of psychiatric services using telecommunication technologies. The growth in the VA, this was 2004, and Dr. Linda Godleski, who has headed up the telemental health telepsychiatry group in the VA for a number of years. This in 2004, you can see that number there was 9,700 veterans, 20,000 episodes of care, and this number of facilities and vet centers and CBOCs were connected at that time. Then Dr. Godleski and her group reported in 2012 You can see this was the outcomes of almost 100,000 veterans that had received telemental health services from 2006 to 2010, and they reported, among other outcomes, a decrease in psychiatric admissions of a substantial proportion for those veterans that had been receiving telepsychiatry and telemental health services during that time frame. Then this study was published. Dr. Gajleski and her group looked at from 2002 to 2014, and cumulatively now through 2014, more than 1.4 million telemental health encounters in the VA system, more than 200,000 patients. And look at 2014 alone, there were 325,000 encounters for 106,000 patients two years ago in that single year. So the growth in the rate and usage of services has been explosive in the VA system. There are a number of other projects that I'm going to touch on just a couple of them, and there are many others that I could talk about, and I'll reference the places if you have an interest in looking more in depth at other projects. There's plenty of information about them, but I'm going to touch on a couple of them here this morning because I think they highlight one of the things in terms of delivery of care is the idea of sectors of care. We've all participated in different sectors of delivery of care, whether that's the private sector, the academic sector, the public sector, the VA, community mental health system. Now, while there are overlaps and interfaces between these systems, a lot of difficulties for patient care delivery have stemmed from these often stovepiped systems providing care in some extent almost isolation from the system next to it or in conjoint to it. And in Virginia and in other states, psychiatry has a long and positive tradition of academic and public sector collaboration and participation in providing academic expertise into public sector systems. In Maryland, for many years, John Talbot in Maryland was instrumental in helping public sector psychiatry and state hospital systems benefit from the talent, expertise, and dedication of academic sector. In Virginia, similarly, there was an ongoing collaboration between academic departments of psychiatry and state hospital systems. And I think telepsychiatry has the potential, and already does, has the potential to revitalize those types of collaborations, to reinvigorate relationships that, for one reason or another, are very difficult to maintain, in part due to economics, in part due to geography and distance. But I think telepsychiatry in different ways provides a platform and opportunity for those relationships hopefully to be strengthened and revitalized. Some of you may be familiar with some of the projects I'm going to talk about. This project in the state of South Carolina is essentially a telepsychiatry network that has provided services to emergency departments across the state of South Carolina. The University of South Carolina sort of serves as the coordinating center for this process. But there are 13 psychiatrists, most of them in the Charleston, South Carolina area, and there are 23 hospitals that participate across South Carolina in receiving consultations in their emergency departments from psychiatrists through telepsychiatry. And they've been doing this since 2009, and they've had over 25,000 emergency telepsychiatry consultations. And they've looked again at a number of issues, but one of the things that they were most interested in is because, as is the case in different states, there's a process where patients in emergency departments who have psychiatric needs for hospitalization, and there are limitations in terms of where beds might be available, they spend inordinate amounts of time, sometimes days, sometimes weeks, depending upon what state and what location. And so they were particularly looking at reducing the length of stay in emergency departments associated with mental health issues and situations, and obtained a substantial reduction. And they also conduct ongoing residency training, specifically in telepsychiatry, methods, usage of technology, issues of telepsychiatry, et cetera. They use their system for that purpose as well. In North Carolina, the East Carolina Telepsychiatry Center, in collaboration with a statewide network, North Carolina Statewide Telemedicine Project, that's what the NC STEP part stands for. They have coordinated a statewide network, again, focusing on emergency service provision that connects 71 hospitals across North Carolina with psychiatrists for emergency consultation. And again, they too have showed a similar reduction in time in the emergency department, improved outcomes, reduced admission times, reduced commitments. This one in Texas is interesting. Anybody here from Texas? From Texas, okay. Have you ever heard of this particular project? Yeah, MHEX. That's mental health emergency centers. Texas had the idea that they would create basically freestanding stabilization units, not connected to a hospital, but freestanding. And they had attached crisis beds and an emergency evaluation component. So if you were under an emergency order in Texas, you could be brought to one of these centers, the MHEX. If you were admitted to one of the crisis beds, there, the psychiatric services, 9 of them as of last year at these 9 MHEX, were all being provided by telepsychiatry services. The emergency evaluation, the daily inpatient rounds on the residential service, all of those were being provided remotely by psychiatrists, most of them not in Texas, including a psychiatrist from Israel providing services to a location there in the rural parts of Texas. And so they too, in their reports, note a similar significant reduction in the usage of the medical emergency department for psychiatric admissions and length of stay. Research studies, do any of you, used to be the research area in telemedicine was sort of a smaller group of journals and publications, but the literature in this area has also grown over the last 20 years. And basically, in validation studies, and these are examples dating back a number of years, that have looked at particular disorders and have done validation studies, face-to-face assessments versus remote assessments, using structured interviews, using specific scales, looking to validate that you indeed both could diagnose, evaluate, provide similar assessment services for a variety of conditions, schizophrenia, obsessive compulsive disorder, major depressive disorder. And so those were sort of early on kinds of studies, namely, could you do this accurately, safely? Were there issues in terms of the components that are necessary to provide psychiatric services in different settings and to different patient populations. Since that time, there have been a lot of studies. This was a summary, a meta-analysis of 14 studies. This was done in 2002. And in those studies, a total of 500 patients. And they looked at assessment instruments using, again, face-to-face and telepsychiatry methods, and really found little significant difference in accuracy or satisfaction between those methods. Just as a personal note, in doing telemedicine oneself, you find early on that there are a number of surprises or things that I was surprised by. I remember seeing a woman who I'd treated on the inpatient unit for a number of years with schizophrenia. She had issues of abuse. And when I began seeing her for the first time over the Telepsychiatry network, she reported in the course of her satisfaction survey that she actually preferred to see me over the television network than face-to-face. Now, once I got past my ego issues and wondered about that, it became pretty clear why that would make sense. I mean, she had significant difficulties with issues of intimacy, issues of male-female intimacy, abuse issues, and felt that the distance obtained in that process was calming, that she was able to be more forthcoming than she would be in the face-to-face encounters that we had had. And you would run across things like that that were surprising in terms of one's practice. We looked at, could you do Ames assessments using, because obviously that's a face-to-face clinical exam. So we sent raters face-to-face and distance, and we looked at doing face-to-face and remote assessments and found a very high correlation. But the interesting thing that we found that we didn't expect was that there were some subtle fasciculations and early signs in the buccolingual areas of several patients that we actually picked up better using the high-intensity focus cameras of the telemedicine project, because it could focus very closely, much more closely than you could do with your own eyes without invading the person's space. And again, that was surprising, that there were perhaps ways that the video conferencing itself would add and subtract from face-to-face delivery of care. The research areas have continued to grow. This was a review in 2003 that looked at a broad number of projects, case studies of a wide variety of locations, rural areas, vet centers, and again, identified that this type of activity, particularly in areas where the alternatives were at times non-existent. It's one thing if there were sufficient psychiatric manpower for everyone to have a high-quality interaction with a board-certified psychiatrist anywhere in the United States. It's unlikely that it's never occurred. It's unlikely to ever occur. So the question is, can this supplement or insert service into areas where otherwise the service would be very limited? Okay. Where does this all go? This is the speculative part. When I was in college, that was 1975, I was taking a computer programming course in BASIC and COBOL and Fortran I don't even know if these languages exist anymore, but some of you remember, yes. And we spent an entire semester in a basic programming course, me and 3 other colleagues, and we designed a program. At the end of that, it printed a banner. Y'all are not stunned with the accomplishment that I felt when we were actually able to print a banner after having spent an entire semester writing a program language to actually accomplish that particular activity. Similarly, when I was in medical school, this would have been 1981 in Richmond, the Medical College of Virginia, it had one of the first, if not the first, electronic medical records in the world, in the United States, which meant as a third-year medical student, I could run from West Hospital all the way over to East Hospital, where the center that had the electronic medical record on its one computer, and I could put in the handwritten orders that the resident had told me to run over there and put in 1981. We've come quite a ways since all of that. And 20 years from now, this process will be different than anybody in this room will really conceive of. But these are some of my ideas about factors affecting where this is likely to go. In mental health care in general, there's the system issue of how do you integrate care, both in regular primary care, in other areas of medical care, and in mental health systems in general. How do you integrate those care systems? It's a huge, it may be the single most driving force in American healthcare these days, is looking at the integration of healthcare processes and systems. Of course, we have an aging population. We have an aging psychiatric manpower population in terms of both numbers and distribution, because it's really not even about the absolute numbers. The National Health Service Corps studies years ago demonstrated you could theoretically have enough manpower. The problem is a distribution one. There are areas of the country where you trip over psychiatrists, going block to block. I lived and practiced in Northern Virginia and Washington for a couple of years, and there's no dearth of manpower in that area of the country. The problem is a distribution one. Gets back to that question of how do you get a psychiatrist to move to Hayside, Virginia? So it's not just an absolute number, it's how do you distribute the resources available. And even if you have those, there's also a timing issue. Psychiatrists, we have our own structure. Well, I'll see you in the clinic 2 weeks from now when my first appointment comes up. I need the service now. I need the service in the nursing home. I need the service in the jail that I got arrested and put in last night. Well, I don't go there, right? In terms of, I go to the clinic. And so the structure of systems and the availability of resources, even if you have the absolute number, it's the timing. When is it available? When can the resource be available? My regular job right now is running an assertive community treatment team. I developed at Mount Rogers Community Services Board the first assertive community treatment team that serves this Appalachian part of southwestern Virginia. So for the last 10 years, I've been mainly going out and doing house calls in the hollers, in Speedwell, or Saltville, or wherever. And the model of assertive community treatment seeks to address that idea of getting out of our box, getting out of our clinics, getting out of the structure and delivering care directly in other locations. And that's going to increasingly be the case in all areas of care, providing a team-based service, providing consultations to psychiatric extenders of care, physician assistants or nurse practitioners or clinical psychologists or teams of mental health providers. That's increasingly going to be the role of psychiatrists as well as providing direct services. It already is in lots of areas. And then in-home services, which I think is going to be the largest growth of mental health and medical services, is going to be the delivery of services in people's homes on an ongoing basis. So there are all these system issues. Then there's also technology forces that are also driving this, the bandwidth accessibility issues, electronic records, and the increasing availability and ubiquity and comfort level that people have, our patients have increasingly with communication technologies. If you do child and adolescence, and you do it by telepsychiatry, kids not only get this, they're extraordinarily comfortable with it. In fact, they'll show you how to use the camera or move things around or do things that the provider doesn't know how to do with the particular system. So the comfort level of receiving services is also going to continue to increase. But of course, there are challenges. Sometimes I used to use the word obstacles. Then I like challenges better. Initially, I used barriers. That was even worse. Then obstacles, and now maybe challenges. Reasons why you can't do this. And there's lots of things written about the difficulties, the cost, how do things get reimbursed. Well, there are 41 states now that provide Medicaid reimbursement for telepsychiatry services that are equivalent to psychiatric services being provided face-to-face. In 1995, there were 0 states providing Medicaid reimbursement for telepsychiatry services. There was legislation passed last year at the federal level looking at requiring Medicare reimbursement for telemedicine services, the first time in 20-some years of attempting to get some of these cost issues lined up. Bandwidth availability, obviously that too is going to increasingly direct and drive services. I've been looking for some time at mobile applications because I'm doing in-home service already. The bandwidth availability in Saltville is still a little lacking. There isn't any, at least in terms of mobile access, providing ongoing services. Those things are changing literally almost month to month in terms of availability of bandwidth. Licensure and credentialing. When you think about this as telemedicine has typically been, as what's called a hub and spoke model. You have a center, you have psychiatrists, you have clinics out here, they're providing services. The question is, how do you credential people in that process in terms of that requirement? And also, how do you license people if you're going across state lines, for example? And organizations like the American Telemedicine Association and other organizations have really had an ongoing look at the question of licensure. You know, is there a federal licensure process? Is there a reciprocity process that enables state licensures and state boards to regionally license providers? Now, this issue has been very contentious, and lots of states have specifically identified telemedicine statutes to say, you can't do this unless you're licensed in every single location where the patient is located that you're providing service to, then you can't provide ongoing telemedicine service, except, of course, in the VA, which is, again, one of the major reasons the VA has had an advantage systemically in this regard is because It's not bound by 50 state licensing processes. Although there are some groups, I know of the teleradiology group that's been in practice for years, and their providers maintain active licenses in all 50 states. All 50 states. I won't tell you how much that costs, but it costs a lot. But the amount and volume of reads that they do and scans and makes it, I assume, cost efficient for them. But that entire process, I think, has to be re-examined in terms of how do we distribute healthcare in this rapidly changing environment around us. Privacy issues. I could, again, have another presentation about is Skype HIPAA compliant? The short answer is no, it's not, as far as the most recent determinations that I've seen. FaceTime is a more complicated discussion in terms of there are many in the technical areas who believe that, in fact, in the right application and with the appropriate safeguards, that FaceTime structure very well could be and very well may be HIPAA compliant. But those are issues that have to be resolved to some extent if you're going to have ongoing video conferencing delivery. Now, there are a number of private platforms and company platforms that provide video encrypted software technology for you. You can look in your latest edition of Psychiatric Times or Psychiatric News, and there are telepsychiatry jobs, positions, companies, all of which use a variety of informatics technologies that are encrypted, that provide the provider with essentially a turnkey solution in electronic records and system delivery and malpractice insurance, and all of these issues are addressed. But in doing them, one does have to make sure that those areas are addressed adequately. So 2021, you could see telepsychiatry groups providing services in multiple different states. Maybe people have a streaming video channel in their home